Okay, welcome everyone. Thank you for taking the time to listen in today. We hope it's going to be interesting and informative. We've got some great speakers today, true innovators, experts in their field. So if I can just take a moment for everybody to introduce themselves, starting with yourself, Anne, if you can just give us a quick overview.
Yeah, thank you, Paul. Good afternoon, everyone. My name is Anne Highton, and I'm an associate with Radar, but I also work for the Lancashire and South Cumbria Integrated Care System on their maternity and paediatrics programmes as the governance advisor.
Thank you, Anne. Alistair?
Hi, everybody. My name is Alistair Frost. I'm the Vice President of International Patient Flow at a company called Vital Hub, and we too work with Radar in terms of aiding patient journeys flow.
Thanks, Alistair. And Amjid?
Hi, everybody. Amjid Mohammed. I'm a consultant in emergency medicine. I work at Calderdale and Huddersfield NHS Trust as head of service. Also work at Doncaster hospitals. And myself and Paul have been working on some innovative projects over some last few years or so.
Thank you. And I'm Paul Johnson, CEO at Radar Healthcare, and I'll be kind of conducting things as we go through this. The general gist of today is really about discussing the part that technology and data plays, in fact, what it can, does, and should play around the whole patient journey. So the idea being is we're going to take you literally through the point of a patient arriving at hospital through A&E, the process that then goes through in terms of identifying of when that patient could be discharged, through then how we interact and get that onto follow-on care, and then looking at the wider kind of ecosystem, looking at the ICS world. So if I can hand over to Amjad, who's going to talk us through that kind of initial entry into the healthcare system from an A&E perspective and his views around that.
Thanks, Paul. Can we have the next slide, please? So the typical patient journey, if you come in through A&E, has remained essentially the same over many decades. Patient comes in, they get registered, they sit down, they may get triage, and then there's an awful period of time which is can drag on for many hours, really, while the patient sat there doing really very little. There's no engagement with the patient, there's no conversation with the patient, and that time is really lost, and we call this downtime. And I think that this is probably one of the biggest kind of unused resources in the NHS. If you add this total time up with the total number of attendances in the emergency department, that amounts to about 50 million man hours that are lost in the emergency department waiting rooms for simply patients sitting there doing nothing. Most of our patients, 80% of them, come in and by their own means. 20% arrive by ambulance, and those 80% that arrive by their own means have a perfectly sensible conversation with the registration, with triage, and then they sit down and they use their own means to try and occupy themselves. Usually they'll be on their smartphone, or they'll be able to they'll bring a book with them, or some means of kind of occupying themselves during this prolonged waiting time, because they're aware that this is going to happen. But what if we turn that around a little bit? What if we actually use that downtime and wasted time and made it really useful time, and actually use a bit of technology to be able to engage the patient during this time? And what can we do through engagement? Well, we can take information from that patient during that period of time, which allows us to understand the needs of the patient, the needs of the person, but also the needs of the problem that the patient's presenting with. So if we engage the patient during that time, we'll be able to get lots of information from that patient that will drive healthcare for that patient, particularly in that patient journey, but also future patients and future patient journeys as well, when we look at data-driven healthcare. What we can do is engage the patient. If we can engage the patient, we can empower the patient by allowing them to be part of the care that is being provided in the emergency department. And even something as simple as actually the patient writing their own story, writing down the reasons why they are in the emergency department, can feel ever so empowering. Currently, what we have is a patient who will attend, they will have their notes written by the clinician, and actually, that may be secondhand information and may contain several errors and mistakes and may be incomplete and may be fragmented. How about if we allow the patients to put their own data, their own medical records? That's enormously empowering. Once we've empowered that patient and we've engaged that patient, we can start the process of education. And again, using technology that already exists, what if we could advise patients around the best means of accessing healthcare, about their own personal health behaviours, health needs, while they're in the emergency department and even after they've left. And this is during that downtime, during the time when nothing currently happens. And if we do that properly, if we engage and if we empower and if we educate that patient during that time, then we've got a better way of delivering healthcare and better way of using that time spent in the emergency department. Can we have that next slide, please? Sorry. So globally and in the UK, this applies as well. Between 25 and 40% of all patients go through the emergency department every year. That's 25 to 40% of the total population of that country. So in about a 5-year cycle, we're talking about nearly 100% of the population going through those emergency departments in those hospitals. And if you then, as I say, add up all the time that's wasted in the emergency department, in the UK, that's 25 million patients, approximately 2 hours while they're sitting in the emergency department doing nothing, then that's 50 million hours in the UK alone. And if we can then use those 3 E's, the engagement, the empowerment, and the education, to drive the healthcare process in the emergency department, then what we can do is to make lots of really nice things happen, lots of really interesting things happen. And we've kind of summarized this in this model called emergence. And just for kind of the sake of definition, emergence is a concept that says applying simple rules to a complex situation creates some order out of chaos. It's a bio-evolutionary term, and we can use this in emergency medicine, mainly because the first bit, emergence, sounds like emergency medicine, but actually, the kind of rules apply in a similar type of way as well. And the top point that we want to start off with is to repeat what we've already said, that the patient's time in the emergency department should not be wasted. Okay, so what we've said is that all the patient's time is valuable to the patient, because the patients value their own time. As clinicians, we value our time. As nursing staff's time is valuable. Admin time, staff is valuable. But we hardly ever think about the patient's time as being valuable. And if we can do that bit, if we can understand that the patient's time is valuable to the patient, then maybe we can as well. And if we then think about the waiting patient as an opportunity and not a threat, then we can start thinking about, okay, actually, what can we do during that waiting time for that patient? It's important to be able to make sure that we look at the patient as this opportunity, as an opportunity to change not only their the manner in which they're kind of perceiving their current health problem, but also the health behaviors, and try and make some long-term changes in the patient's behavior. We've got a captive audience here. We've got a captive audience of patients that are sat there for many hours doing nothing. This is the biggest opportunity that we are missing. And how do we capture that time? Well, we need this patient-centered process. And that's how you deliver patient-centered care. Everybody talks about patient-centered care. It's a great theory, but actually what we currently have is a service-centered care. And the service will see the patient when the service is ready to see the patient. The patient arrives, they can sit there for many hours, and they will be seen when the service is ready. And that's not good enough, not in this day and age. What we need to do is to start the process of healthcare as soon as the patient arrives. That's patient-centered healthcare, and we can do this with the technology that's currently available. After all, every other service is doing exactly the same. You wouldn't be left in an airport without, if there was a delay in your flights, without the appropriate level of ongoing information, ongoing dialogue with yourself and the people who are trying to kind of manage this situation. And we should be the same. We should be fully aware and cognizant of this wasted time and try and make this our processes build them around the needs of the patient rather than around the needs of the service. We also need better engineering to kind of use that wasted time more effectively. If you look at a turbo engine, it uses waste gases to be able to make that engine work better. That's what we're using here. We're trying to use wasted time to make our services work better. And again, to do that, we need to be able to provide in-reach care into the patient while they're in the emergency department, but also after they've left. What we often see in healthcare broadly, but also but specifically in emergency medicine, is that we offer services in silos, individual silos. And what we need to do is to make sure that that patient, we can follow the care of that patient even after they've left the emergency department. So the care that's provided should be really following the needs of the patient rather than following the needs of the service. Okay, the patient came to the A&E at 10 o'clock, left at 2 o'clock. That's not the end of their illness or their injury. Their injury or illness will resolve over a period of time, and we should have the capability and the capacity to manage the care of that patient even after they've left. So this is the outreach component of emergence. To make all this efficient, to make all this work better and gel together, we need network solutions. And the reason why we need them is because there's a massive economy of scale over here that should work in our benefit. If you go to my hospital and 6 miles down the road you go to a different hospital, and 10 miles down the road you go to another hospital, you will get a different set of services for exactly the same problem. So if I've had a head injury, I'll get an advice sheet in this hospital, which is different to the advice sheet at Bradford and the different to the sheet in Leeds. And that isn't right. It uses too much resources. Too many people have to govern that information, when actually there's only one lot of information that we need to give to the patient. And if we network it, we can improve that and improve the governance, improve the structure, and improve the content of that information significantly. One really important part of emergency is actually taking the emergency department brand to the patient, which is allowing that service to be delivered before the patient's even set off for the emergency department. This is particularly so for patients who are looked after patients who are in care homes, patients who are in learning disability environments. So anywhere where it's difficult for the patient to come to the emergency department. The current capability and capacity is there in the system to be able to allow the ED, emergency department brand, to go to the patient. We can see the patient, we can evaluate the patient, we can see how the patient, what condition the patient may be in, and we can try and keep that patient out of hospital. And that's very much more beneficial for the patient than it is to try and drag them into the hospital for reasons that sometimes are not so clear. To wrap all that up is where we started with, which was the engagement, the empowerment and education of the patient, but also the clinician as well. How do we take a big leap from where we are now to where we need to be, and work with our digital colleagues to make healthcare better, safer, and much more cost efficient than where it's been. And although COVID has been a massive threat to healthcare, it's also a massive opportunity. We have learned how to do things differently, and the possibilities are now there, and everybody can see that this can be done. And my view is that it should be done, particularly in services like emergency medicine. Thank you.
Brilliant. Thank you, Amjid. I was just jotting a few notes down there as well, and some things jump out straight away, which, around service-centric, not patient-centric, which I think is a common theme that we're going to see right through this. So thank you very much. I think that in keeping with the patient journey, so if we assume that somebody has now come into the hospital and through the emergency department, hopefully in this new world. So the overall experience has been greater. And we're now in the hospital setting, which is a nice segue to bring in Alistair and hear about MCAP and how that can bring improvements.
Yeah, thank you, Paul. Next slide, please. Yep. So looking at the patient now that they're in service, so the treatment plan has been defined by the clinical team. It's being delivered in the hospital. I think one of the things, as Amjid quite rightly said, that the COVID pandemic has taught us is that the hospital isn't necessarily the safest environment for them to be in, but always there are these unintended consequences of hospital stays. So, patients lose functionality whilst they're in hospital, patients lose muscle mass whilst they're in hospital. So the quicker we can get that part of their care delivered in an alternative setting, closer to home, the better it is for the patient. And the faster they'll move down that journey and hopefully get to a similar stage to the state at which they arrived in terms of functionality, if you can flow them as fast as possible at no risk to their treatment plan. So I think the critical element here is making sure that the treatment plan as defined by the clinicians is delivered. There is no challenge to that plan. The patient is getting everything the clinical team want them to get. But if it can be safely delivered at a setting that is closer to home, then that setting is identified at the earliest opportunity. This also obviously will provide added benefits in terms of flowing the patients faster, and less time in the hospital improves the less likelihood of risk such as infection and any, as I say, the muscle loss or functionality loss, which would increase the reablement requirement. Thus, we have a system that as Paul alluded to, that will look at the clinician's plan of care. It doesn't challenge that plan of care in any way. It just looks at, well, could that plan of care be delivered in an alternative setting? Similarly, we're looking at reducing the variation in that decision, whether the patient could be discharged decision, and where that patient would be best suited in an ideal world. And then obviously if that setting doesn't exist or is full or unavailable, we can also record and build up a picture for commissioners. Well, this is what you may need more of in an integrated care system if you want to flow patients through the acute capacity as quickly as possible for their benefit. Next slide, please. So the UK NHS and all healthcare systems are incredibly complex, and particularly complex for a patient not knowing their way through this and how they move and guide through it. I think there are 30 different levels of care delivered in medical surgical care and about 14 levels of care delivered in mental health care. So it's hugely complex to know the best setting in which a plan could be delivered. MCAP will help that process and deliver consistency of that process, and certainly where we've implemented it, to identify the points at which a patient is now well enough to move to the next level of care. You will see that the medically fit for discharge list that is recorded at most hospitals will double. It's saying, okay, well, they are now medically fit to go to another level. If that care is available, the treatment plan that the clinician has defined for them could be delivered in that setting. MCAP will also deliver and identify those blockages, which enables certainly an integrated care system to look across the whole pathway of the patient. Where are the patients getting blocked? Because if they're getting blocked at lower down their pathway, you see that blockage reverberate up through the system into, and then equally makes the problem and life on A&E and the waits, which hopefully now will be better utilised, the waits on A&E because there are no bed availability for the patients that they need to admit. And as I say, for an integrated care system, which the healthcare system in the UK is moving towards, we're certainly looking to define, well, based on the patient's acuity mix, what levels of care do we need to provide in this system? And if we do provide them, how do we identify the patients at the earliest opportunity in a consistent manner for those patients to be flowed to the closer to home, which is clearly better for the patient, and clearly better for the system because it means the more expensive resource, but acute, is better utilised and flows improved. And I think at that point is where we would hand over back to Paul to say, if we identify the patients in the settings for flow to the most appropriate setting for them, then I think that's really where Radar takes over.
Thank you, Alistair. I think from a previous conversation as well, something that was highlighted was the existing process without having this kind of technology, in that there's bottlenecks in terms of the time of day that people will do the rounds to identify which patients are discharge candidates. And I think what the message here is that this is almost continuous and in real time, and presenting these as and when they occur, so that throughput improves. Is that correct?
Absolutely. It's a live system, so at any point in time everybody has the single version of the truth, or one version of the truth, of exactly which patients need to be in which setting, and why they're currently unable to take that next step towards it if there's a blockage. So as a tool, that live list is used in sort of gold, silver, bronze commands to identify, well, who is it if we really need to make capacity for emergencies such as the pandemic, or even as in across Manchester during the Manchester bombing. How do we identify the group of patients that we could safely move to a different setting? So yes, it's very much live, as opposed to retrospective. What was happening yesterday and what was available in the community at that point in time.
Perfect. Thank you, Alistair. Can we have the next slide, please? Okay. So I think, again, picking up from the kind of the patient journey. So we've now had somebody come into the A&E. We've improved that whole experience. I think even maybe that we extend it before they have arrived at A&E to prevent people even turning up. But ultimately, we have a patient, they've come into the hospital, and then we've heard from Alistair how we can expedite that whole discharge process and support the clinicians, support the front end staff. And I think the kind of compelling takeaway was that this deterioration of a patient whilst in hospital, that is significant. And just to add some colour, just before I explain as to how we link all this together, is the size of the problem. And pre-pandemic, just taking the stats from February 2020, there were 150,000 delay days in that month. So that's 5,000 or over 5,000 patients that are delayed. They are stuck in hospital. So it's identifying as to where we ideally want to get them home first, or we want to find a safe place for their follow-on care. And I think that's really where we're talking about these integrated solutions. And these systems will integrate and speak to each other right from that original place where that patient arrives at the A&E, as they're going through their process within the hospital. And as we start to take that feed from systems like MCAP, we're able to present that data and say, well, actually, I've got a patient here. I can't send them home yet. They do have some rehabilitation, some follow-on requirements. And then what we're able to do with systems like Radar Healthcare, and what we do is, because we're an integrated, interoperable system, we engage with social care providers, intermediate care providers, home care providers, supported living. And so what we can do is match that patient requirement as it's starting to come through that hospital and in their journey. We can start to align before they even get to that intermediate care ward. We can start to align their follow-on care. We understand capacity, capability, COVID status, assurance, patient transport, and so that as soon as that patient becomes that candidate for discharge, and engaging and empowering the patient, picking up from Amjid's points, we can then align that follow-on care. And I think the benefits are clear and obvious in terms of the efficiencies that we can bring about to the NHS and to the social care providers that are going to provide that follow-on care. But ultimately, it is the improved outcome to that patient. We've reduced their stay, the length of stay in hospital. We've reduced that delayed transfer of care and improved that overall patient experience. So I think for me that it is that the patient outcome has improved. So I think that's a really good point to kind of bring in Anne, and how this ICS, how do we stop people getting into hospital in the first place, population health management, patient inequalities. There's a whole range of things that have been tackled there. But when we're looking at a system-wide view, and again, just using this patient journey, I think it'd be good to hear from Anne in terms of the whole ICS and looking at it through that lens.
Thank you very much, Paul. So what I would like to do in my part of the presentation is just to draw on my experience whilst working within the Lancashire and South Cumbria integrated care system, and just explain why, in my opinion, integrated technology is an absolute must and not a nice thing to do. So currently, within the NHS, there are a number of different technology solutions throughout the whole system, throughout the different providers of the system. And the technology providers are doing different things with different outcomes. This results in an inaccurate data collection system-wide. Inaccurate data, inaccurate outcome measurement, and it also results in organisations managing data in silos. Just for context, I'll just give an example of one provider within our ICS. So this is one trust. In one trust, there may be 3 to 4 different digital solutions, and they're all collecting their own specific data relating to the patient journey. And that could be an adverse event, it could be a complaint, it could be some litigation data. Usually these systems don't talk to each other. So again, it's back to that silo working. Therefore, the process of data analysis, mitigation, audit, and monitoring is onerous and is reliant on individuals within specific teams and departments. This has a negative impact on resource and time, and it also results in a comparison of apples for pears, because if you're not comparing the same thing, then you can't get an accurate reflection of what the risk issue is within the organisation. It's speaking a different language within one organisation. That's just one provider within our ICS. And just for context, I'm just going to tell you how many organisations there are in the Lancashire and South Cumbria ICS, and I have to read this to make sure I get this right. We have five provider trusts, 5 ICPs, 4 local authorities, 14 district councils, and 4 local universities. Taking that provider one, for example, let's just consider how ineffective that model is throughout a whole system. And our system is a relatively small one. A lot of the integrated care systems throughout Britain are a lot larger than ours. Therefore, it's a far more detailed plan. It's my opinion that an integrated digital approach throughout the system will eliminate the burden from any one organisation. It will act as an underpinning function. As a result, data analysis or mitigation will become more proactive. A data-driven approach will be adopted where the technology will be telling us where there may be potential issues and challenges, as opposed to what currently happens, where we have to trawl through data, analysing it, cross-referencing it, and looking for issues reactively. And therefore, there's a time limit induced in between the actual incident happening, for example, and the analysis. Smarter data sharing across a system will then result in everybody using the same data analysis, data evaluation, using the same metrics. Therefore, everybody will be speaking the same language, and therefore it allows for apples comparison. It's a consistent approach, and therefore it'll strengthen partnership working, because as these partners within the ICS start to work with the integrated technology, they'll all be speaking against the same metrics, and they'll all be working towards a beneficial end, which is obviously the outcome to the patient. I think finally, the recent white paper has imposed a duty for people with, or for organisations within ICSs to collaborate. Integrated technology will help the collaboration. It provides population data across the system, which enables effective population management and therefore the management of health inequalities. Model 1 that I described in the first instance just won't do that. In my opinion, the only way forward is an integrated technology approach. Thank you.
Thank you, Anne. Again, just picking up some things there, which is actually a really great segue onto the next slide, actually, please. I suppose, there was a big piece about apples and pears and data, and, it's really interesting that I was on that review about the ICS white paper, and, what struck me was that there were all these disparate systems, and we were in danger of creating more and more silos and those siloed data sets. So I think just the kind of infographics there is that the systems that are in place at the moment, this is demonstrable technology. This isn't something that we're proposing that's new. These systems like Radar Healthcare, we have what's called open APIs and integration servers to allow that interoperability. We can pass data through, and this isn't just about connecting those data points. We're connecting organizations. And then, picking up on Anne's point, that I think that is the only way that we're truly going to be able to underpin these ICSs. Next slide, please. So just touching on the data. So there's no doubt that in all of our ecosystems, in all of our respective worlds within healthcare, there comes a point where we have to enter things into the system, or something is automatically entered into the system. And so we've got that data entry. And then it is that I don't want to harp on just about the data set, but it is so important in terms of how this underpins a lot of that activity. And that is, if you look at the flow of that data, we have that initial capture, it feeds into the reporting. And reporting doesn't have to just be those historical, typical management reports that we have. We're talking about meaningful information that can generate real-time interventions, alerts, notifications. As things are happening, predictive analytics, we can start to see that there was a great example that we were discussing a couple of weeks ago, which was due to COVID, there is a high number of agency staff, junior doctors, less skilled personnel on shift within hospitals, which presents a higher risk or patient risk. And therefore, if we can identify and forecast as to when that's going to occur, we can start to predict when patient harm is likely to occur. So we can drive interventions, we can put shadow leads on, there's a whole range of things that we can do. And then insights. So the insight, again, is using AI technology. So with machine learning and AI technology, for too long it's been a frightening phrase and people sometimes don't fully understand it. Ultimately, in simple terms, we are asking technology and the systems to do the hard work, do the processing, try and understand what these things are meaning to us. And then from that, it can present to us insights that we can act upon. This is actionable intelligence that we can start to apply to improve the service, to do those real-time interventions, and to improve overall patient outcomes, which kind of leads to the outcomes themselves, which they're clear and obvious. We give back time, you save costs, we improve regulatory ratings, reputation, all those kind of things. But again, coming back to it, I think the key outcome is an improved patient outcome. Next slide, please. And kind of brings on to a summary, and I know we're going to ask everybody just to kind of what their key takeaway is from the session. So I think starting with yourself, maybe Amjid, just to, from your perspective, your summary and key takeaway for today.
Thanks, Paul. So yeah, I think the main thing is that to improve emergency care, we need to bring the patient with us. We need to have this patient-centric process that absolutely kind of helps the patient help us. And at the moment, the patients feel somewhere between helpless and hopeless when they come to AED sometimes. And we need to stop that. And by helping patient do that, it's going to be highly effective for the patient, but highly effective for us. And this, we can, if we can network it, we can kind of broaden it out, put it across the whole integrated care system, then it creates massive benefits for the health service. So I think we've got to bring the patient with us. That's the main thing. I think we can't have a service for the patient without the patient coming along with us and effectively holding our hands and walking into this new future.
Brilliant. Thank you, Amjid. Alistair, if I can ask you for your kind of the summary from your perspective, what you'd like people to take away.
Certainly, thanks, Paul. Yeah, for us, it's all, in the hospital environment, the earlier you can identify a patient to be flowed safely closer to home, delivers demonstrable benefits for their care, delivers demonstrable benefits for them, but equally capacity and efficiency for the system. So you can free up capacity for other patients who require those services. Everybody's been saying, from a patient's perspective, saying actually, if we can deliver your care closer to home, then to remain in a hospital bed is detrimental to your health.
Brilliant, thank you. Anne, if I can ask from your perspective, key takeaway and summary?
Yeah, thank you, Paul. My key takeaway is I think that organisations within integrated care systems need to realise that technology has significantly improved and changed over time, and technologies like radar can significantly help the patient experience, help improve the patient experience. It's my opinion that integrated technology isn't something that should be talked about as, oh, wouldn't that be nice? It's something that has to be implemented as soon as possible so that the patient experience can be improved and the population health can be improved.
Brilliant, thank you. The key thing that listening to everybody speaking today and my own general views is that it is around that patient-centric care model. That actually, if we do focus on the patient and those patient outcomes, we will naturally deliver the other benefits and efficiencies that we talk about. I think as well that, we touched lightly on COVID and the pandemic, but, it has taught us some lessons. But as we start to come into that kind of reset mode and we see the resumption of elective care, then these challenges will be compounded. When we talk about 5,000 patients in hospital when they don't need to be, that whole throughput and patient experience, it's essential that we act now when we start to apply these technologies and start to look at them as answers and start to really look to implement them now and not later. Next slide, please. I think hopefully people have found that informative, interesting. Everybody's details and profiles, I think, are all there, and people can access the deck, etc. And love to hear any questions and answer any questions.